in this lecture, we want to kind of build on what we talked about in the previous lecture, and that was that hemodynamics lecture where we looked at the concepts of blood flow, velocity of blood flow, and the resistance concepts. Obviously, on a day in and day out basis, there's the potential for the amount of resistance that your blood encounters to its movement or to its flow to change. Like I said, this can occur on an hour-to-hour, a day-to-day basis, and over the course of a lifetime, obviously that resistance would change as well. Well, when you look at it, as we talked about previously, you have to generate enough pressure to overcome that resistance, and that's how you ultimately maintain flow. So all of that being said, what you should begin to appreciate is that at certain times you will have a need to try and alter the pressure in order to maintain flow or alter the way in which flow is going on at that given time. So that's what we're going to start to look at. We're going to start to look at here the way in which you control blood pressure, and in part by controlling pressure you will also obviously influence flow. And when we approach this concept, we're going to kind of approach it from three different perspectives. The first would be the neurological or the nervous system regulation. Secondly would be hormonal regulation. And then thirdly, we'll look at some of these other factors that collectively we kind of throw up underneath this concept called autoregulation. And autoregulation is the ability that some organs have to self-regulate their own pressure. Image here shows you kind of the setup for the nervous system regulation of blood pressure. And it's a kind of similar pattern that you see throughout nervous system control in many different items. And that is the fact that you'll have receptors located throughout the body. Those receptors will send information to your central nervous system. In the central nervous system, that message will be integrated or summarized into one coherent signal. And should you need to alter your blood pressure in one way or the other, you'll see motor neurons or efferent neurons leaving the CNS that will communicate with effectors, ultimately to cause the changes. So that's the pattern, but let's look at the specifics. We'll start here with the receptors, or the inputs to the cardiovascular center. This is the information that's supplied to let your nervous system know if it needs to alter your pressure. The inputs come from one of four main items. The first would be your higher brain centers, or higher cortical areas. These would include structures such as the limbic system and the hypothalamus. These areas are controlling basically your emotions, and they're also the hypothalamus is receiving a lot of sensory information from throughout various regions of the body. You also have three different groupings of receptors called proprioceptors, baroreceptors, and chemoreceptors. These three different groupings of receptors monitor a variety of different parameters. The proprioceptors monitor joint movement. As your joints move, well, your muscles would be used. And because you would be using muscles, you may need to alter the pressure, because as your muscles become used, the velocity of flow of blood flow will need to increase in order to deliver more nutrients and more waste to your muscles in a given time period. So proprioceptors can alter, once again, blood pressure and therefore blood flow. We see baroreceptors, which directly monitor pressure, and also chemoreceptors, which monitor blood chemistry. All of these are sending information back to your central nervous system, and the area to which they send that information is the cardiovascular center, which is located in the medulla oblongata. In the cardiovascular center, all of these messages are summarized into one coherent signal. Now, if your cardiovascular center says, all right, I don't need to change my pressure, well, then nothing happens. But should your blood pressure need to change, maybe your resistance went up, or maybe your resistance went down for that fact, and now your therefore can come down. Well, then it has a series of efferent or motor neurons that it can communicate via, that will ultimately allow it to reach or communicate rather with the effectors that can cause a change. Now, when we look at this, the CV center that is called the cardiovascular center for a reason. Cardio is heart, vascular is vessels. So it has the ability to influence what your heart and also your blood vessels are doing. And by influencing what your heart does and what your vessels do, it can change your blood pressure. So let's take a look at how that happens. In order to communicate with the heart, you'll see two groupings of nerves. These nerves should look somewhat familiar because they are discussed in chapter 20. They are the vagus nerve and the cardiac accelerator nerves. The vagus nerves send parasympathetic stimulation to the heart. Remember, your parasympathetic division of your autonomic nervous system is the quote-unquote rest and digest division. So this is going to allow your heart rate to come down. And therefore, if we begin to expand this concept a little bit into what we discussed in chapter 20, where we looked at cardiac output, remember, cardiac output is equal to heart rate times stroke volume. So if your heart rate begins to decrease because of the effects of the vagus nerve, which carry parasympathetic, begin to decrease as well. As your cardiac output decreases, what this will cause to occur is an actual decrease in your blood pressure.
Change can ultimately also change your blood pressure. What will occur is that your heart is literally the organ that pumps blood into the system. So if the heart pumps out less blood, in other words, if your cardiac output decreases, well, then your blood pressure should fall. If we look at the other side of the coin, considering your heart rate increasing, which will be an effect of the cardiac accelerator nerves that carry sympathetic stimulation to your heart, as your cardiac output increased, your blood pressure would rise. So the cardiovascular control center affects blood pressure by changing cardiac output. Remember, cardiac output is the amount of blood ejected by a ventricle per minute. So by ejecting more blood, in other words, by forcing more fluid, more blood into the system, the pressure should begin to rise. That's what happens when we see the cardiac accelerator nerves do their job. When you have a decrease in heart rate due to the vagus nerves and their parasympathetic stimulation, cardiac output will begin to fall, and therefore blood pressure can also fall as well. Now let's look at what the cardiovascular center does in relationship to the blood vessels. When we look at the effector nerves going to, or the efferent neurons going to the blood vessels, you're going to see that there's only one set. They're called vasomotor nerves. These vasomotor nerves carry sympathetic tone and can cause vasoconstriction. Now vasoconstriction will cause an increase in blood pressure. A long time ago, usually in chapter 18, I mentioned this, but when we look at altering blood pressure, vasoconstriction causes blood pressure to increase, vasodilation causes blood vessel to decrease. So, if the cardiovascular center dictates that your blood pressure needs to increase, well, you can have those blood vessels vasoconstrict due to the effects of the vasomotor nerves, and blood pressure will begin to rise. Now, if you look at this diagram, there's a parasympathetic stimulation to the heart as well as a sympathetic stimulation to the heart. We look at the other half of the coin, and we don't see a parasympathetic stimulation to the blood vessels. All we see is sympathetic carried via the vasomotor nerves. So the question becomes, how can you cause a parasympathetic effect within the blood vessels? And it's not as complicated as it may seem at first. In order to get a parasympathetic effect with the blood vessels, all you have to do is turn off or shut down the vasomotor nerves. Vessels have elastic tissue within their walls. That elastic tissue would take over. The vessels would begin to recoil, and they would literally dilate and get bigger, and therefore allow the pressure to begin to decrease. So this diagram is a nice one to take a look at as far as when we consider the neuroregulation of blood pressure. Kind of sets up that nice little relay system of sorts. Make sure you take a look at it and understand the outputs especially, and also where they're going and what's occurring. Now, for the sake of time, and I usually don't emphasize this on your exams, so we're not going to concern ourselves with the reflexes that are seen underneath the neurological nervous system side of regulation. Instead, what I want to do now, don't believe it's in this set, so I'm going to just stop flipping here, and I'm going to actually go back, and I'm going to pull up a new file here very quickly if the computer will allow me to do so. And that is going to be a file of text tables. And in this table, or using this table rather, we're going to begin to discuss the hormonal influences over blood pressure. The emphasis here should be on the hormones that are influencing blood pressure and what effect they have overall on blood pressure. So as you take a look here, you can see we're at table 21.2. You can see three different parameters: cardiac output, resistance, and blood volume. All three
if you change them, will have some effect on blood pressure. Now, several of the hormones in the middle column you've already seen before. Like I said, you should know what effect these hormones have on blood pressure. So, for the sake of time, I'll just kind of very briefly talk to you about them. First, norepinephrine and epinephrine. These are fight or flight hormones. They're going to have several effects that ultimately, overall, will increase blood pressure. Now, sometimes these hormones may have a localized effect and they can decrease blood pressure in local areas. But the overall effect with epi and noepi will always be an increase in blood pressure. You can see that increase in blood pressure is caused by increase in the heart rate and contractility. Remember, they are positive inotropes, and they are also involved in the endocrine side of things when we look at regulating heart rate, so they can increase heart rate. And they can also cause vasoconstriction if we begin to look at the vascular resistance aspect of it. So both norepi and epinephrine will cause an increase in blood pressure. Angiotensin II, a hormone we mentioned in chapter 18, causes vasoconstriction, which would lead to an increase in pressure. Antidiuretic hormone actually has two different ways to cause an increase in blood pressure. It can cause vasoconstriction, but remember, it also causes the kidneys to begin to retain fluid. Well, the retention of fluid increases blood volume, and also vasoconstriction both increase blood pressure. We look next at aldosterone, and this is a final hormone that I'm going to mention with an increase in blood pressure. Aldosterone causes increased sodium reabsorption by the kidney, but with that reabsorption of sodium comes water. So technically, at the end of the day, aldosterone can increase blood volume as well. Therefore, it can also increase blood pressure. So, hormones increasing blood pressure are norepinephrine, epinephrine, angiotensin II, antidiuretic hormone or ADH, and also aldosterone. Now, there's one hormone out of this list that you'll see that will ultimately be allowed to decrease blood pressure, and this is the one that I want you to keep in mind: atrial natriuretic peptide, or ANP. A hormone secreted by the heart, the atria specifically. It's released usually when your blood pressure is too high and your heart is having a hard time ejecting blood. As ANP does its job, it would lower your afterload and make it much easier for your heart to eject blood, and therefore, hopefully, the heart wouldn't be as backed up, quote unquote, there as it normally may be. So, that's kind of a short snippet there of some of the hormonal influences over blood pressure, but like I said, definitely want you to keep those in mind. Finally here, autoregulation. Auto, once again, this is just usually the ability that the organs or tissues themselves have to regulate their have the ability rather to regulate their own pressure. We see this a lot with skeletal muscles, sometimes certain areas of the brain. Basically, the more an organ or tissue is being used, the greater the amount of blood that it may need. That's because as it's being used, it would use up nutrients. It would use energy. It needs to replace those nutrients and energy by having additional nutrients flow toward that area. In order to do so, what organs will typically do is try to decrease their blood pressure, which will drive more flow towards it. Typically, this occurs in skeletal muscles as they become warmer, as lactic acid possibly builds up. These can all cause vasodilation within the skeletal muscles themselves, and that vasodilation would lead to a decrease in pressure. We can see it in the brain a lot of times. When you're using certain areas of your brain, the blood flow to that area increases due to the simple usage of that area. So, autoregulation is what happens when these organs alter their own pressure in order to increase, or in some cases decrease, the blood flow based upon what may or may not be needed at that given time. Alright, so those are the three concepts that fall up underneath this regulation of blood pressure. Like I said, make sure you kind of keep in mind those points I made about the neural, hormonal, and also the auto-regulation of blood pressure.